Sharon?
Dr. Shah, don't cause any trouble.
John, where are you? I can't see you.
Wait a minute. No, I'm listening to you.
Where are you?
Oh, hi, Anna.
Yeah, there you are.
Yeah, I turned my camera off. So, how you guys doing?
Yeah,
Yeah,
great. Haven't seen you in a while. How have you been?
Very good. Very good. Very busy. Busy. I'm glad to say busy.
Okay, there's two Annas, one Anna and one Anna, right? Okay.
Oh, follow both the Annas.
Both the Annas. Yeah, I know. It's
Does,
interesting.
does everybody know how to screen share and everything?
Yep.
I think
Yeah.
they should be good, right?
John?
Yeah, Abatha, everyone know how to screen share?
I think so.
Okay.
John, Dr. Nasir's welcome is with me. So I'm
Yeah.
just going to see if it runs, okay, John?
Okay.
Okay. Oh, Anna's gonna. Okay, who's gonna moderate? Are you gonna moderate, Abby, or?
I'm going to moderate. John?
Okay. Okay. I'll just turn it over to you, and then you just handle picking the speakers and the questions. Okay.
Okay.
Okay, you can see this? John, Sharon? Yeah, okay.
Ladies and gentlemen,
Yeah. Hey, good day.
Okay, so you can see this, right?
Yes, we can. We can. Yeah.
Okay. So this is, I already have his recorded thing. He's going to join, but I already have his recording.
Okay.
You have his presentation recorded.
Yeah, it's just some opening remarks.
Okay, I'll let you handle that.
Sharon?
Yeah.
Yeah.
Okay, you can see me, right?
I can see you.
I don't know. Sneha and Anila have not joined in yet.
Oh, I just ran from the OT and I've come.
You ran. Okay. Friday is a holiday for us here, so lucky.
Okay.
Yeah, but I work on
So Abby, you're gonna handle any insubordination?
Oh, you're going to handle it.
You're gonna handle Abby, right?
Yeah, I'll handle it with you. You handle it.
Okay.
I remember previous ones were like really
Mute.
new. Okay.
Yeah, we have 13 minutes.
Okay.
So thank you so much, Anna and Anna, for participating in this webinar. It was very kind of you all to join us.
Oh, thank you for inviting. It's always
Hi to me. Yes.
It was not easy for us to get people who do functional and epilepsy actually. And then we had some last minute things, some people backed out and things like that. So anyway, hopefully we get through this.
Very nice.
Yeah, we haven't done this in over a year, right, Abhi? More than a year.
Yeah, more than a year. Last year we didn't do any.
Yeah, we did a lot in 2019 and 2018. Yeah, 2018. Then we stopped in last year. So we started again this year.
Oh, great. I'm very happy.
Yeah, but this year we plan to have more women speakers.
I saw.
nice.
Yeah, we used to have more men speakers. So I mean, you all are doing the same work out there. So I think it's good we showcase ourselves. Yeah.
And how big do you think is going to be the audience? How many people you are expecting?
I don't know. Usually, how many do we get? Abhi, about 100?
I don't know, depends actually.
Oh.
We are a little early. If you were next time, we'll do it a little later. But then the timings clash. Because here in India, if it is around 5:36, then the audience increases because everyone's done with their work and stuff, right?
Yeah.
So we're a little early, but let's see. We have spread the message wide. Let's see how many join in.
Hi, Sneha.
I'm sorry. Hello, everybody. Hi.
Hi.
Okay, so you're free today, right?
Oh, I managed to be outside the OT. So I think we've spread the flyers, so I hope people do join us.
Yeah.
People to join, yeah.
Dr. Kato's here.
Oh, she's here. Good.
Yeah, she just got.
Just Prof. Nasir then.
I put this fake background a while ago, and I don't know how to change it anymore.
Oh, okay.
I want to switch it up. I mean, it's super nice, but it's not as nice.
Oh, you can, I think usually.
I can delete it. What happens if I delete it? Oh God, no, that's not appropriate.
Because you can side click your video.
Blur. Let's okay. I'll do this one.
Go to the choose bar.
I
Yeah,
found it. This.
Okay.
Yeah. Let's do the blur.
I know you can actually put a lot of fancy backgrounds, right?
Yeah, and then people think you have a super nice house, but
Oh yeah, you can do that. You can make your you have a
exactly.
library or something. What time is it there, Anna? It's morning.
It's 9:30. It's 9:30 in the morning.
And Anna, what time is it in Brazil? Is it middle
In
of the night?
Brazil, it's 6:21 in the morning, a.m.
Okay.
And just so we're gonna have all the questions at the end. Is that correct?
Yes, correct.
Okay. Okay.
Do you want it to go as yeah? That's what we decided, right, Abhi? At the end or after each? Unless unless any one of you needs to go. No, right?
No. What I might do at some point, I might have to disconnect and then I'll reconnect.
Okay. All right.
Okay, but so that I'll be back for the end when you do all the questions.
Yeah.
Okay.
So
I
people
think
can ask their questions on the chat, and then we'll do it at the end.
Okay, perfect. Then
Sneha will help collect the questions. So at the end, maybe both us, we will try to whichever the question to whoever the speakers was, we will read out the question and then you can give the answer. All right. We have a neurosurgeon from Mongolia. Is it? Hi.
Greetings, everybody. I'm Dr. Bennett. Avatar has been appointed the head of the handling cases of insubordination. So you've got to stick to your times because Abby, I have to leave in 2 hours exactly. Okay.
Yeah, I know. Abby told me. Yes.
I know.
Yeah. Matter of fact, Atul speaking. Yeah. So I don't. You guys, are you tight for time? You got just all the speakers and everything.
I think we have. I think we should have.
Yeah, there's no problem as long as we stay around 2 hours. But I have to leave.
Mm-hmm.
Yeah, no.
And I can see Dr. George has joined us.
Hi.
Hello, sir.
Hi,
welcome.
hello.
Thank you very much for your,
Chitra.
acceptance in the literally the last hour.
My pleasure. My pleasure. Thank you very much. Hello, Dr. Anna, Dr. Abida, Dr. Sharon. Hi.
Yeah, thank you so much, George. You're a lifesaver.
Thank you so much. Thank you. My pleasure. I think only Abida, me, and Sneha in the same time zone. Rest of you are all in a different zone altogether.
Yeah.
And I heard Dr. John speak something about insubordination. I was really, that's a very heavy legal term. So what is the?
Yeah, well, we have serious penalties.
Is it the capital punishment for those who who are accused of that?
That's right. 1 week in Miami Beach.
Oh.
then everyone is going to be insubordinate.
Exactly.
Hey, Dr. Kato, are you there? Maybe not. She stepped away. Okay.
I just saw Dr.
I
Kato.
think John is not aware that Dr. George is a legal expert as well.
Oh.
Oh.
Medical
not,
law.
not an expert, an area of interest. That's all.
Okay, we have 6 minutes.
John, where's Anila?
Yeah, I know. This one. Let me message her.
Yeah.
Oh, there, Prof. Nasir has come on.
Okay, he's come.
Yeah.
Hello,
Hello, Dr. Nasir.
my name is
Hello, sir.
Nasser Al-Ghandour.
Hi.
How are you?
Welcome.
Thank you
Welcome.
for a kind invitation. I am honored to be with Professor Yuko Kato and with all of you, really.
It's an honor to have you with us.
Thank you.
You took your time to join us. It's very nice. It's in the early in the morning there, right? Too, right? It's in the
Yes,
morning?
yes. But I'm like John Bennett working 24 hours.
No, I'm sorry. I'm sorry. That's not possible.
Good evening, Professor Kato.
Hi, how are you?
Good.
Everybody looks very fine. Thank you very much for organizing such a wonderful meeting. Thank you. Sharon, you are very active.
No, I'm
Well,
not.
you know, someone said in the chat, he's from Mongolia. There's 4 women neurosurgeons there.
Oh,
Yes.
I see.
Can you speak,
Yeah, can she
Bayam Batson? Can you share what you just told me about? Are you there? We're not live yet.
Oh, she was there earlier. She's not on screen anymore.
Oh, okay. Well,
Yeah. Oh, that's her name, Bayam Batset. It's yeah, it's very, very, very unique name.
Yeah.
Yeah, that's very popular name in Mongolia, I think.
Okay.
Hi, Radab. I think Noor has joined as well. Hello.
Yes. Oh, yeah. Nice to have you on.
Hi, yes, I'm here. Thank you so much. I'm really honored to be presenting. Thanks a lot.
yeah, there's Noor.
Yeah, hi.
How you doing?
I'm doing great. Thank you so much. It's a huge honor to be among such a wonderful faculty class, really. Thank you so much, ma'am. It's a huge honor to
日本はどこにあるの？日本はここだよ。日本はここ。見てみる。ここ。見えるパパが。
Professor Kato, good evening. How are you?
Hi, good evening. How are you? Your place is in the morning or?
Yes, we are early in the morning now. I would like to thank you for giving me such opportunity and such honor.
No, thank you very much for your kind invitation for all of us. Thank you very much.
Thank you very much. Thank you.
Hello, Dr. Kato. Hello, Dr. Kato.
Hi, John. How are you?
It's been a long time.
Yes.
Since
So
Nepal.
You work so hard.
Oh, I love it.
Day and night.
It's good to see you. It's good to see you.
Very nice to see you. Thank you so much.
Okay, we started.
Where are you on? Where are you now? U.S.
Yeah, Miami Beach. Miami Beach.
Miami Beach. Oh,
it's 5:30 in the morning here.
Oh, thank you so much.
It's neurosurgeons hours.
You're right. Yes. 24 hours.
Okay.
John, you're practically a neurosurgeon now.
Yeah, that's the only thing I do that's in common with a neurosurgeon.
Unfortunately, Dr. Ipe, he moved to India.
Yes,
no more in Nepal.
No more in Nepal.
Yeah, I see.
Yeah, he's heading a big department there in Krishna. He's going to start to be more active. I think you're going to see him. Matter of fact, this weekend, I think maybe you're speaking. You're speaking this weekend, right?
Yes.
Yeah, at IPE's conference. Yes. So we'll see you there. Okay, 1 minute.
Professor Nasir, I will share your talk from here, right?
You have my talk already. I sent it to you.
Yes, yes.
Can you
I
share
have.
it, please? Thank you. Thank you.
You want to try it? You want to try it? You know how to do it.
You want to try it?
Yeah, she tried it earlier. Was okay, right, Abi?
Yeah, I've tried it. It's okay. Yeah.
Okay. Okay.
Hello, Professor Yuko.
Hello.
Hello, how are you?
Oh, hi, how are you?
I'm fine, thank you.
Thank you for...
Okay,
Hello,
Verdab.
everyone.
Okay, Verdab, you work for Neurosurgical TV now, okay?
Hello,
Okay,
Dr. John.
No, and you introduce Abitha, okay? Abitha Shah. She's a neurosurgeon from Mumbai, okay?
Okay.
Okay, so you say, when I go 10, 9, 8, 7, 6, 5, 4, after 1, you say, hi, I'm Verdab from Georgia, okay? I'm not on the screen. It's all about you guys, okay?
Yeah. Hello, Dr. Nasser.
Hello. Good morning, John. How are you?
Can we start? It's 5:30.
Yeah, it's time.
All right. Okay.
So, Verdab, you ready? After I go, okay, ready, Verdab? Hello, Verdab?
Dr. John, I prefer you just start the remarks.
Oh, okay, I'll just start and then I'll just turn it over to you after I start, okay? Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. It's Dr. John Bennett broadcasting for Neurosurgical TV. We have the pleasure of broadcasting for the Women's Neurosurgeons Organization, and I'll let Verdab take over from here. Hi, Verdab.
Hello, Dr. John. How are you? Hello, everybody. It's always an honor to have this very informative and useful webinars. So we just turned this pandemic into something useful. So I'm Redab from Jordan. I'm officially certified and neurosurgeon here with double boarded with the European board last year, and practicing it in Jordan, Amman. So we'll start with Dr. John. You'd like to introduce Abida?
Okay, I'll take over from here. So it'll be easier.
Yeah, Sharon. Yeah,
all right, I'll just take over.
This is so organized.
Yeah, all right. Okay, so I want to wish a very warm welcome to everyone to our ACNS WIN webinar. It's the first of many series, and it's the first for year 2021. So today's webinar is on pearls and wisdom of functional neurosurgery and epilepsy surgery. So it gives me great pleasure to introduce this key figure who has been instrumental to the women in neurosurgery movement in the world from the beginning. She is the first woman in Japan to become a professor in neurosurgery. She's the founder of Women's Neurosurgical Association of Japan, and she's also the founder of ACNS Women in Neurosurgery. So it is my honor to welcome President of ACNS, Professor Yoko Kato, for the opening remarks.
Okay, thank you very much. Maybe I want to share the several slides after my short talk. Okay, so it is my great pleasure to cordially welcome all of you to join the ACNS webinar 2021. So all of us are gathered here with a unified aim to deliver the knowledge of neurosurgery to young neurosurgeons who need to learn the core concept for improvement. The practice, gaining sophisticated clinical application is not possible. So without the knowledge of basic science in disease. So good practice of the neurosurgery should be combined both. So I just really welcome all of you to enjoy this webinar. So the very strong, powerful, the lady neurosurgeon can be the speakers tonight. And for the violinist and the hope, it can be inspiration for all violinists to move forward on their career. So I want to share a little bit the several slides. Is okay?
Yes. You can go ahead, Prof. Kato. You can share your slides.
So this is a very simple slides. So just I want to share, actually I'm not the first lady neurosurgeon in Japan.
Yes, professor. Yes, professor.
No, professor also, yes.
Okay.
Yeah. Anyway, so Wind's goal, what is Wind's goal? I think the interaction, nurture the scientific, the thinking, and promote research, and encourage the healthy interaction towards social issues. They promote gender equality among medical students and the residents and the YNS and the neurosurgeons. So now we face a very hard fact because there's so many patients are waiting, and also the service through the education. So training of the surgeons by imparting quality efforts. How the wind neurosurgery can help the use of the experience of the senior surgeons and develop sustainable surgical programs of the education and the focus on the countries in need, rather than providing of the episodic the service alone. The goal of the service through education, supply infrastructure, and local support and equipment, and the certification and education program. So the win with the societies and the WFNS, the partnership with the local neurosurgical society and the WFNS for the one curriculum and the milestone standards. The second, the combined educational efforts, such as boot camps. And third is the program for exchange of the educational opportunities. The fourth is a travel to their partner site for 3 months period of the simulation laboratories of observationship and educational opportunities. So when with the local neurosurgeons, the working on the modernized communication to allow the real-time the conference, the patient discussion across the world, and the fourth, and the interoperative consultation through the first screen, the communication of the interoperative endoscopies and the microscope. So understanding the infrastructure challenges. So just I want to share the several slides because we have so many the women neurosurgery in the world. So I went to several places such as Boston. We had a very gathering during the World Federation. And second one is Spain. And also the Uruguay is so many lady neurosurgeons. Then when I visited Mongolia, we had such meeting. And also the Taiwan, they have next please. And also this was 2002, quite old pictures. I said it was first the late Kanaka and Peter Black and Gail Russo. So the already we had such a gathering for many years. So this is the picture from the Myanmar gathering. So unfortunately, there's some tragedy, some political issue. And this is when neurosurgery, sometimes we had a gathering of, with the student or nurses. So Nepal, Morocco, Kazakhstan, and also Karachi, Pakistan, Dubai also. Next. And this is when I visited Africa. Africa also, there's so many lady neurosurgeons. We cannot forget the Africa, the South, the Latin America also. So this is a picture from when I visited Senegal, the West Africa. And this is Gabon. Next. And again, this picture, Abida Shah in the picture, and Isabella, me, and the late Kanaka, and the Limpen. Next. And also, this is a gathering in Algeria. Algeria has so many lady neurosurgeons. Maybe we will have some another chance to have some meeting with them. And so many places where I visited. And this is Sudan. Do you know the Sudan? Sudan divided into two places, two countries. So Persakando, and this is a 2009. So many lady neurosurgeon was working. And this is when I visited India, almost 4 years back. They had a inauguration. And
I think the name stresses quite a bit. And at this time, if you have a support that she's helping all of us, we look forward. And I'm so happy that it's happening here in Chennai with our first ever, which is a thing which is very dear to me. And
my first visit in India was almost
very happy, and then
lady neurosurgeon. Okay. So the future direction of the ACNS or ACNS women neurosurgery is a continuing contribution of education activity in neurosurgery, increasing the number of the high quality young neurosurgeons through Asia and improved outcome of the neurosurgical treatment. Thank you very much. So I wish all of you to have a very nice the first webinar, which is organized by the ACNS, the WIN. The topic is epilepsy, functional neurosurgery. Thank you very much.
Thank you, Prof. Kato. We have a special guest today, Professor Nasir, who is actually the president of the Egyptian Society of Neurological Surgeons. He's also just started off the WIN chapter for the Egyptian Society. And it is my great pleasure to actually welcome him. And he has a little speech prepared for us. So Abi, can you go ahead and play his speech?
Can you see it, Sharon?
Yes.
Yes, I'm going to start.
Yes.
It's a great pleasure to welcome all of you in the Asian Congress of Neurological Surgeons Women in Neurosurgery webinar series 2021. Today's webinar in particular is about functional and epilepsy surgery, peers, and wisdom. First of all, I would like to thank Professor Kato for her kind invitation and for the hard work she's doing with all her team in order to promote neurosurgery in Asia and worldwide. Professor Kato is also supporting neurosurgery in the African continent with the outstanding educational webinars she's organizing and through the donations from her own money to Sub-Saharan Africa. As Honorary Secretary of the Continental Association of African Neurosurgical Societies, the CANS, and as President of the Egyptian Society of Neurological Surgeons, the ACNS, and on behalf of all African and Egyptian neurosurgeons, I would like to tell her thank you with all respect and appreciation. I would like also to thank all our speakers today. I will go by the order by which they speak with preservation of titles. Abida Shah from India, Sarah Ozon from Australia, Anna Mizaroji from UK, Maria Noureddin from Pakistan, Anna Mora from Brazil, Anila Darbo from Pakistan, Jer Russo from USA, and Sharon Thaifulas from Malaysia. Thanks to all of you for contributing to this neurosurgical activity and for giving much of your time. Sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. as second Vice President of the World Federation of Neurosurgical Societies, WFNS, I understand that one of the most important missions of our organization is to promote educational activities among all young neurosurgeons, especially in the developing countries. I'm particularly pleased and humbled by the active role played by the Asian Congress of Neurological Surgeons in the process of education and training. I'm also looking forward to develop and strengthen collaboration between the Continental Association of African Neurosurgical Societies and the Asian Congress of Neurological Surgeons for the benefit of African and Asian young neurosurgeons. I already organized 30 webinars since the beginning of the COVID-19 pandemic, many of them under the theme African-Asian collaboration. And today, I am honored to announce the foundation of the Egyptian chapter of Women in Neurosurgery under the support of Professor Yuko Kato and her team. Together, we are organizing a webinar next Friday under the name of Egyptian Women in Neurosurgery, 26 March from 2 to 4 p.m. Egypt time. May I take the opportunity to invite all of you to participate in this important event. Ladies and gentlemen, my best wishes for today's webinar to be successful, as all webinars previously organized by the Asian Congress of Neurological Surgeons, and we will be always working together. Thank you.
Thank you very much, Prof. Nasir.
Thank you very much.
So now, without wasting any more time, let's start off with our webinar. So the first speaker for today will be our very own Education Chair Committee of ACNS WINS, is Dr. Abida Shah. She's actually a distinguished assistant professor in neurosurgery at ZGS Medical College and KEM Hospital, Mumbai. She holds high levels of expertise in skull-based neurosurgery, vascular neurosurgery, open and endovascular, craniovertebral junction disorders. Now, the thing about Abida is, whenever she presents anything, it is very interesting, especially when she gives us her anatomy presentations. I think everybody loves her anatomy presentations. So here is Abida. She's going to present anatomical correlates relevant for epilepsy surgery. Okay, Abi.
Yeah, thank you, Sharon, for this great introduction. You can see my screen?
Yes.
Okay. Sharon, stop me, okay, if I'm running over time.
Okay.
Okay. So welcome everybody to this first ACNS WIN webinar. And as we do everything in neurosurgery, we have to start with anatomy. So let us begin our webinar on functional and epilepsy surgery with some anatomical correlates that are very important to all of us. So when the primitive amphibian left the ocean and became a reptile and then became a mammal, earlier there was only a brainstem and with a thalamus on its head. The olfactory system developed as a projection from here, and then the cortex developed in humans. So these are the three kinds of cortex that we have. The primitive cortex, which is the allocortex, which consists of 3 layers. So earlier, as soon as the olfactory system developed, you had the archicortex, which was on the medial aspect, and the paleocortex, the olfactory or the pyriform cortex, which was on the lateral aspect. The limbic structures developed around these cortices in a C-shaped manner, forming a medial cortical ring with a mesocortex of 6 layers. So you have paralimbic structures, that is the insula, parahippocampal gyrus, and cingulate gyrus, and the insula itself. Lateral to this developed the isocortex, which has 6 organized layers, and it consists of the parainsular structures and the neocortex. Today, the focus of our webinar will be on the temporal lobe, because the temporal lobe is the seat of epilepsy. The reason for this is the temporal lobe has a mixture of all the 3 cortices in them. So you have parts of the archicortex, which is the amygdala and the hippocampus in the temporal lobe. You have the paralimbic structures of the mesocortex, which is the insula, parahippocampal gyrus, and the cingulate gyrus. And then finally, you have the isocortex or the neocortex, which surrounds this. So having an amalgamation of all these cortices gives rise to a series of events, and that manifest as epilepsy. So we start with the anatomy of the temporal lobe. This is the lateral aspect of the temporal lobe, which we are all familiar with. So this is the superior, middle, and inferior temporal gyri, separated by the superior and inferior temporal sulci. The superior and the inferior temporal gyrus always meet here anteriorly, and the middle temporal gyrus just starts behind it. The superior temporal sulcus and ends in the supramarginal gyrus, and you can see that the superior temporal gyrus continues with the supramarginal gyrus, and the middle temporal gyrus continues with the angular gyrus. So the lateral part of the temporal lobe is neocortex. Now let's look at the inferior part of the temporal lobe. So this is the parahippocampal gyrus and the uncus, which is part of the mesocortex. This region here, that is the inferior temporal gyrus as it has turned down, and the fusiform gyrus. These are parts of the neocortex. This is the collateral sulcus separating this fusiform gyrus from the parahippocampal gyrus, and the inferior temporal occipital sulcus that separates the fusiform gyrus from the inferior temporal gyrus. So this region here, if you see this area is actually known as the temporolimbic passage. So this part of your temporal lobe is the neocortex, whereas this part of the temporal lobe is the mesocortex. So this is a beautiful connection between these cortices and is known as the temporolimbic passage. This is the rhinal sulcus, which separates the uncus from the rest of the temporal lobe. And finally, the medial aspect of the temporal lobe is the parahippocampal gyrus. The parahippocampal gyrus continues upwards as the cingulate gyrus and continues posteriorly in the occipital lobe as the lingual gyrus. Anteriorly, it bends over itself and forms the uncus. So again, this is the mesocortex. We'll go to the archicortex as we dissect in this region. So we start from the inferior aspect. You have the uncus here. That is, you see the close relation of the uncus to the cerebral peduncle. The uncus, anterior part of the uncus, harbors the amygdala, and the posterior part of the uncus harbors the hippocampus. And they're both separated by a sulcus in which the anterior choroidal artery runs to enter the temporal horn. There are various nuclei of the uncus, but maybe in another lecture, because others we won't finish. Again, another important relation here is that of the posterior cerebral artery and the cerebral peduncle to the uncal region. So you can see in the ambient cistern, in the crural cistern, how the uncus is related to the posterior cerebral artery and cerebral peduncle, which is again very important while doing amygdalohippocampectomy. So we start dissecting from inferior surface. What I've done is I've removed the gray matter of the inferior aspect of the temporal lobe. So this is the optic tract. This is some gray matter of the uncus that is left. And what you start seeing first here, you see these fibers here? These are the fibers of the radiation of the cingulum. The cingulum, as it turns, it comes and ends in this inferior aspect, and this forming the radiation of the cingulum. Here you can see the fibers more clearly. These are the terminating fibers of the cingulum. Once you start removing this radiation of the cingulum, you will start seeing the ependyma of the temporal horn. This thin layer here is the ependyma. You open the ependyma and you see the magnificent structure of the hippocampus. So this is the head, the body, and the tail of the hippocampus, and it is lying in the temporal horn, as you can see here. It forms the floor of the temporal horn. Another important relation in the roof of the temporal horn is the amygdala. And at this juncture, at the utmost anterior aspect of the temporal horn, both these structures meet together. Again, important while performing epilepsy surgery. Now, what I've done is disconnected the hippocampus downwards. You start seeing the choroid plexus. Once I lift the choroid plexus and reflect it, you start seeing another fiber bundle that is beginning here. So this is the optic tract. This is the lateral geniculate body. Fibers originate from here, go over the roof of the temporal horn, turn posteriorly, forming the lateral part of the temporal horn, and this is the Mayer's loop. Again, very important to preserve during epilepsy surgery. So this is another turned view showing the Mayer's loop beginning in the lateral geniculate body, turning into the roof of the temporal horn, and then continuing in the lateral part of the temporal horn. And this is how it looks when you look at it from laterally. This is the Mayer's loop as it joins the other parts of the optic radiation to go into the temporal lobe. And this is the whole internal capsule that has been dissected out. This is the anterior limb, the genu, the posterior limb, the sublenticular portion, the retrolenticular portion of the internal capsule. So we have seen from an inferior aspect, we have reached the hippocampus. Now let's look at the structure of the hippocampus per se. The hippocampus is named after a seahorse because of how it looks. At the anterior aspect of the hippocampus, there are three structures that look like a paw, and they're known as the pes hippocampi. So this region here is the head of the hippocampus, where the choroid plexus starts or the anterior choroidal artery enters, begins the body, and then it curves as the tail of the hippocampus in this region. Thin layer of white fibers on the surface of the hippocampus are known as the alveus. They begin as the alveus and they continue as the fimbria of the fornix, fimbria, the body, the crura, and the columns of the fornix to end in the mammillary body. And as you see, it is lying in the floor of the temporal horn. So if you look from a lateral aspect and start dissecting, this is your superior, middle, and inferior temporal gyrus. So if you start dissecting in the middle temporal gyrus, if you start removing the cortex, you'll start seeing the hippocampus here. So you have the head, the body, and the tail. This is the region of the middle temporal gyrus. So basically your superior temporal sulcus and your inferior temporal sulcus in the depth both reach the lateral aspect of the temporal horn, and this is the floor of the temporal horn. From a coronal view, you can see the hippocampus that is lying in the floor of the temporal horn. Again, this is another dissection to show how the hippocampus curves around the cerebral peduncle. Now, both the fornices meet together, form the body of the fornix, and then continue as the columns of the fornix. These are the crura of the fornix. There is a thin fiber bundle here joining both the crura, and that is the hippocampal commissure or the saltarium. So let's look at it from an aspect that includes the various brain structures. So this is the region of the insula, which I have cut. This is the frontal lobe. This is the temporal lobe. This is the temporal horn. This is the region of the hippocampus. This is the region of the amygdala. And then the hippocampus turning and going and forming the fornix in this region. In the choroidal fissure. The choroidal fissure is bordered by the fornix and the thalamus. So this region here is the choroidal fissure. You can see how it is related to the insular lobe. The insula forms an external shield for all these central gray structures. That is your putamen, your globus pallidus, and your thalamus. So the insula is forming an external shield for these structures. Anteriorly, it is related to the caudate head. Posteriorly, it is related to the tail of the hippocampus, or the body or the atrium of the lateral ventricle. So this is another image where you see this is the hippocampus, this is the region of the amygdala. The next important relation is that the amygdala merges with the globus pallidus superiorly. So when performing a amygdalohippocapectomy, your extent of resection has to be just around this area, otherwise you will reach the globus pallidus. So now we have seen it from the lateral aspect, we've seen it from inferiorly, and now when you see from medially, the temporal lobe forms an intricate part of the limbic system. So this limbic system I will show you briefly, and the Pape circuit. So this is the mammillary body, the mammillothalamic tract, the mammilotegmental tract. You remove the parahippocampal gray. This is the radiation of the cingulum, as I had shown you earlier, comes here around the corpus callosum and ends here in the parahippocampal region to form the radiation of the cingulum. This is the uncus and the head of the hippocampus here. This is the fimbria forming the fornix. This region here is the dentate gyrus, which continues up as the indusium griseum. And the fornix, columns of the fornix, continue to the mammillary body and the mammillothalamic tract and the anterior nucleus of thalamus. So once you dissect in this region, you cut the corpus callosum, you lift the caudate head, and you start seeing the last aspect of the Pape circuit, and these are the anterior thalamic radiation. So I will show you the whole Pape circuit that has been dissected. This is the fimbria, the fornix, the columns of the fornix, mammillary body, mammillothalamic tract, anterior nucleus of thalamus, anterior thalamic radiation, cingulum, and coming back to end in the parahippocampal region, completing the circuit. And then we dissected the whole circuit outside the lobe, and you can see the whole Pape circuit beautifully. This is the olfactory tract and striae, which again form part of the limbic system. So these are the components of the limbic system where you can see all these structures that form part of it. So this was our paper on analysis of the Pape circuit. Lastly, we have to look at the insula to understand this anatomy. So this is the frontal, parietal, and temporal opercula. You open the opercula as curtains. You see the gyri of the insula, the anterior short gyri, the posterior long gyri, separated by the central sulcus of the insula, which has the same direction as the central sulcus of the cerebral hemisphere. So again, when you start dissecting, the major white fibers are the superior longitudinal fasciculus, that is the lateral part. Then you have the arcuate fasciculus, and this is a short arcuate connection between the pars opercularis and the arcuate fasciculus. So more in detail, these fibers are being delineated here well. You can see the SLF2 or SLF3, as I like to call it, the lateral part of the SLF. This is the arcuate here. These are the whole gray matter of the lateral aspect of the hemisphere has been removed, and you can see the tracks very beautifully. Now, why is this important for epilepsy surgery? This few tracks here are very important. This is the IFOF here, and this is the uncinate fasciculus. So as you see in this region, this once you remove the gray matter of the insula, this is the Lyman insulae. Just beneath the Lyman insulae, there is the IFOF and another tract, that is the uncinate. These all form components of the sagittal stratum. Here the arcuate has been cut, and these are components of the sagittal stratum, which consist of the IFOF, anterior commissure, and optic radiations mainly. So this is the IFOF in another specimen. These are tractographic images showing the various fiber bundles. I think you're all familiar with it. So the reason for all this anatomy is while approaching for epilepsy surgery. So you have your IFOF here. You want to enter the temporal horn here. So this is the sagittal stratum, and you have optic radiations or the Mayer's loop in this region. So now I've turned the specimen. If you notice carefully, here you see the IFOF going here, the optic radiations behind it. So there is this one area, small area in this region, where it is completely devoid of any fibers and makes a safe entry point to enter the temporal horn. So you can see here the internal capsule with the optic radiation. The hippocampus I have deflected down. So this region here, see the Mayer's loop form the roof here and the lateral part of the temporal horn. But in this region here, there are no fibers, and you can safely enter the temporal horn from this location. Approaches to the amygdala and the hippocampus have been described through the middle temporal gyrus, through the inferior limiting sulcus, through the pyriform cortex, through the subtemporal region, and again a supracerebellar approach has also been described. And this is how, these are the various images showing the choroidal fissure and how you can approach. Basically, if you enter through the inferior limiting sulcus, there is a risk of damage to this region where there is the amygdala and the tail of the hippocampus, tail of the caudate nucleus, and also to the IFOF and uncinate fibers, which are in the region of the Lyman insulae. Yasser had described this approach for a selective amygdalohippocamectomy, but he modified it later and started entering into the pyriform region. What we do is we use this approach that was described by Professor Goel, and that is the middle temporal gyrus approach from the point that I showed you in the image, which is devoid of any fibers. So this is just to show you in the surgical specimen. This is your surgical view, inferior temporal gyrus, superior temporal gyrus, the middle temporal gyrus has been entered. You can see the hippocampus here. Again, a surgical view. So this is the disconnection that is performed. We disconnect in the region of the tail here, go all the way to the lateral neocortex, remove all these structures, and then disconnect the amygdala and the hippocampus in one block completely and remove it as a complete specimen. So this is our approach for a medial temporal epilepsy. We do not perform a selective amygdalohippocamectomy. We perform a temporal lobectomy along with the amygdalohippocamectomy in one en bloc specimen. So again, you can see this region where we enter, where it is completely devoid of any fibers, safe to enter from here, enter here, make this disconnection in this region, remove the neocortex, and you are safe. Just a few examples quickly. This is a medial temporal epidermoid that I have operated. You can see this approached by an incision in the middle temporal gyrus. Here you can see the intraoperative image. This is the hippocampus, this is the amygdala, this is the temporal horn and the choroid plexus, and the epidermoid has been completely removed. Another tumor in the medial temporal region, again approached by the same approach, middle temporal gyrus. You can see all the fibers are displaced up and safe to enter the tumor without causing any post-operative deficit. And you can see the radical resection. Parahippocampal region tumors or limbic system tumors, again approach to the inferior temporal gyrus with a radical beautiful resection that you can see in this image. So we've described this. We've classified the fibers of the brain into these layers. Sharon, am I over time? Okay, just for 2-3 minutes more.
Yeah, you're over time.
Yeah, okay. So should I stop?
It's okay, Abhi, go on.
Okay. So we've divided the white fibers of the brain into these 5 groups, 4 horizontal groups: superficial, middle, deep, and central group, and the vertical layer or the projection fibers. So this is the image showing all the fibers: the superficial group, the middle group of long association fibers, the deep group in relation to the ventricle, the green circle showing the commissural fibers, and the orange circle showing the projection fibers. Some other important, so we finished with the anatomy of the temporal lobe. Some other correlates that are important for functional and epilepsy surgery is this is the anterior commissure in its entire extent, having a frontal component and a temporal component. The temporal component runs with the sagittal stratum and completely hugs the temporal horn on both the sides as if embracing it completely. As you can see in this image, here you can see the anterior commissure that is coming here. This is the Mayer's loop, and this is the IFOF. All of them come together in this region, forming the sagittal stratum and hug the temporal horn, as you can see in this image. So you see the anterior commissure hugging the region of the temporal horn in this area. So this is the anterior commissure viewed from laterally with the optic radiations and the IFOF. And lastly, the corpus callosum for epilepsy surgery. As we are all aware of the callosotomy procedures that are being performed, this is a recent publication that we have submitted on the anatomy of the fibers of the corpus callosum. So I'll just show you quickly. This is the forceps minor. This is the forceps major. These fibers here are the tapetum. They form the roof and the lateral wall of the temporal horn and of the atrium. Here you can see that the tapetum is ending here as the last layer of the sagittal stratum. There are fibers from the genu that go towards the caudate. And of course, these are the fibers of the dorsal callosal radiation that connect the frontoparietal convexity. So these are the various types of fibers that we've divided this region. Now, important to note in this region is, if you're performing an anterior callosotomy, you can do so in this region because there is no motor fiber in this region. For a posterior callosotomy, you can do it in a small area in front of the splenium, which actually connects the precuneus. So again, this is safe. This region that you can see, the black circle, is a no-no for performing a callosotomy for approaching the ventricular tumors. But if you have to perform a disconnection, you have to perform the disconnection right from the genu to this posterior part of just in front of the splenium. That is when you will disconnect all the motor fibers that are important for getting a good result. So that's the last thing. Thank you very much.
Thank you so much, Abhi, as usual. Very interesting and very concise. Sneha, you want to take over?
Yeah, sure. Thank you, Dr. Abida, for that exciting anatomy lecture as always. And it's a pleasure to introduce the next speaker for the webinar, Dr. George Villanellam, who's an additional professor of neurosurgery at Sri Chitra Institute of Neurosurgery, Trivandrum, the Central Institute in state of Kerala, India. His special interests are epilepsy surgery, eloquent brain surgery, and brain tumors. He's had a special training in epilepsy surgery at UCLA, USA, Los Angeles, and he's trained and mentored several epilepsy surgeons and centers in India, Sri Lanka, and Bangladesh. We're happy to have you here. Dr. George, it's over to you.
Thank you so much, Sneha, for that very warm introduction. I must begin by congratulating all the members of WIN for the fabulous work that you're doing. How you so wonderfully balance your social and your family responsibilities along with your neurosurgical work. It's fascinating to think about it. And let me thank you all from the bottom of my heart, especially Professor Yoko Kato and the entire team mentored by Professor Kato for this phenomenal work that you're doing. When we speak about insula in epilepsy, as perhaps all other intrinsic brain tumors, even in epilepsy, the insula has got a very limited role. Maybe if you take 2 or 3 out of 100 refractory epilepsy patients, only then perhaps you find insular epilepsy as the culprit. But this is such a fascinating topic that I chose to share this with all of you today. And since John has warned me about the 15 minutes time limit, I have kept a timer on, and I wouldn't want to be accused of insubordination. So if you look at the disease spectrum of the insula, you could have so many lesions affecting the insula. The overt lesions like neoplastic lesions and low-grade gliomas are more common. And from the epilepsy perspective, we have focal cortical dysplasias, cavernomas, AV malformations, also inflammatory lesions. And the insula has also been implicated in occult pathology. Perhaps there is a role of the insula in all these pathological conditions like autism spectrum disorders, Alzheimer's, MRI negative insular epilepsy, which is coming up in a big way in the current stereo EEG era. I'll just begin by talking a bit about the basics of epilepsy workup and also the functions of the insula, along with its little bit about its development, because only when we understand it from the perspective of its function and the network can we actually conceptualize the concept of insular epilepsy. And only when we conceptualize it can we treat it well. Now, we know that the insula is a multimodal lobe and performs so many functions. So much so that when you don't understand anything about a certain brain function, I think you can very conveniently place it on the insula. So some of the functions are, visceral sensory motor processing, volitional swallowing, cognitive functions such as language, and the list is just endless. And there are some two functions which are very specific to the insula. One is called interoception, or the eighth sense. If somebody asks you how do you feel, it's not just a feeling of your motor or sensory perception. It's a complex phenomenon that's called interoception. And the second is the function of salience, that is standing out, like how this red chili stands out in this slide over here. So these are the two functions which are specific to the insula. So this is the the right and left insula too. There are functions which are specific to it, but functions which are bilateral to both insulae are perhaps the empathy that we feel and the heart rate feedback that we have. So whose terrain is the insula is the basic question that comes about. Is it the neurologist terrain? Is it the neurosurgeons, the psychiatrists, the epileptologists, the stroke specialists, the anatomists? And finally, the patient might say that isn't it my insula? So that's how the insula is. Almost everybody has something in it. So this is how insular resections came about. Initially, the concept in 1949 by Gilliam and Mazar, and then we had insular cortex stimulation coming up by Penfield in 1954. There was morbidity with insular surgery, which was a slight setback by Sylvanus. Then Yassergil's description of limbic and paralimbic tumors, and currently we are in the second phase of stereo EEG. That is, again, there is a resurgence of interest in the insula. So a basic about drug-resistant epilepsy, we all know that at least 2 tolerated drugs have to be given for a proper amount of time. And even then, if you have refractory seizures, you have the concept of medically refractory seizures. But in the current era, we have a new concept of surgically remediable epilepsy syndromes, wherein you can offer surgery early when you know that the natural history of certain lesions is going to be refractory. And you really don't have to wait for these 2 years to establish medical refractoriness. This is the basic about the epileptogenic zone, which is the smallest area that you need to resect to achieve seizure freedom. And unfortunately, we don't have any ideal investigation. It's only guesswork, because only after the resection and you find a good result can you be very sure if you have found the epileptogenic zone correctly. So the soul of epilepsy surgery is to resect the epileptogenic zone, but it's a theoretical concept, and the ideal resection, which is easier said than done, should include the structural abnormality, the MRI, the electrical abnormality, which is probably seen by an electrocorticography, and at the same time, we must preserve functional cortex. So is it an epileptogenic zone because you have some big resections where patients are not free of seizures, while at the same time partial resections where patients are very happy and completely seizure free? That is when an alternate concept of the epilepsy network by Susan Spencer came about. And it is this network concept which actually holds good in many of the insular epilepsies that we treat. So as we know that epileptic lesion that we see is often the tip of the iceberg. You tend to underestimate it, like how the captain of the Titanic did. So where do you do your surgical strike? That's the big question. So the basic pre-surgical workup starts with the most basic MRI and video EEG, going up to the invasive monitoring, stereo EEG, or direct subdural grids in the current era. And the future perhaps will be more less invasive and more customized. No one size fits all for any pre-surgical workup, because every man's epilepsy is different. So why is the insula so special? Because it's got a very precarious location. There's an enigma about its functions. It is draped by an end artery. It has got very precious perforators, and it drapes the capsuloganglionic structures. Why insular epilepsy is so special? Because the surgical Sylvian split, is so challenging, and that's perhaps the first big micro neurosurgical step that you tend to take as a neurosurgeon. Most of these patients are, functionally intact, and even small deficits for them can be very devastating. Why insular epilepsy is so special is because the semiology is a little atypical. It can be hidden from scalp EEG recordings, and the insula can be independently, the seizure onset zone, or it could be part of a very large epilepsy network. And it's often implicated in failed temporal lobe epilepsy surgery. Perhaps 30% of failures are because of an insular contribution. So what we shall discuss perhaps is a bit about the function dysfunction, newer modalities for insular exploration in epilepsy, how we could avoid surgical adverse events, and what's the future of insular epilepsy surgery. So as Dr. Abida very wonderfully pointed out, the insula perhaps is a part of the paralimbic system as described by Paul MacLean. And it's not really a part of the Papez circuit, but it has got relay stations to the Papez circuit. And it's a part of a part of the allocortex and also a part of the mesocortex. The anterior insula is allo, while the mid and the posterior insula is mesocortex, the mid in its evolution. And the insula in a child or in an embryo is perhaps more prominent structure, and as the neocortex grows around, the insula gets buried deeper and deeper. And it literally means that the insula is just an island. So if you have a friend who's coming from an island like Sri Lanka, I think it wouldn't be incorrect if you literally call him an insular man. And that the concept came from the Roman insula, where you had small isolated quarters where the Roman soldiers stayed. And it's the fifth lobe of the brain as described by Clark, and it's all these 5 lobes together which give us that unique characteristic of our brain. And the island of Reel is how it was first described by the person who described it first. Mel Gibson is on the slide because here we have one guy who has an island named after him, and here is another guy, a Hollywood star who owns an island, Mel Gibson. So do all these animals have in development anatomy and insula? Yes, they have one. In fact, humans have it, have the neocortex covering it, while these insulae are more easier to approach. It's got a very heterogeneous cytoarchitecture, and there is a granular and an agranular area, which is all complex. And is it really an island? Not so, because except perhaps the occipital cortex, almost every part of the brain is connected with the insula. It's not an island, it's a misnomer. So this is cortical evoked potential, perhaps, which will help us to establish that. And this is the concept of temporal plus epilepsy, where the insula is part of a complex network. So if you just resect the temporal lobe, you're not cured of your seizures, because the insula also has independent ictogenesis. So insular epilepsy is a great mimicker, because it could mimic frontal lobe epilepsy, it could mimic temporal, it could mimic parietal. So this is depending on the spread of the epilepsy pattern. And I'll quickly show you an insular seizure. This is how it looks. You can see this young lady waking up. Suddenly she has a choking sensation. It's as though someone is strangulating her. And this is the typical insular semiology. And this is insular cortex epilepsy, means that the insula is where the ictal onset happens. But insular seizures could happen even if the seizures spread to the insula. So an insular seizure is not equivalent to insular cortex epilepsy. And the scalp EEG can be extremely non-localizing and could mislead us in insular epilepsy. And in the current era, stereo EEG perhaps helps us to establish the network. This is a little girl who had bilateral insular exploration on stereo EEG. And this is how you could see how focal is the onset, just a very focal onset from maybe a mid-insular contact. So stimulation of the insula is would help to evoke all these sensations perhaps. And if you have any trip to do to the insula, if you these days you need to go somewhere, you need a map of the place, that's the structure. You need to understand the routes to go there, and you should also know what could happen if something goes wrong, misadventures and mishaps. So this is the structural anatomy, very wonderfully told to us already by Dr. Abida. Quickly going through it, there's a circular sulcus around the insula, and there is the central sulcus again in the insula, the anterior 3 short gyri and the 2 long gyri posteriorly. And this is how it looks. And the coronal section is also very important to, very fascinating to see the gray matter at the junction of the white matter and the gray matter in the depth of the insula at the level of superficial to the putamen. That is also very fascinating. This is how the insula looks on a CT, a thin ribbon. The insula on the MRI again is a very fascinating structure, and the arteries of the insula help us, to be mindful of their presence, so that we could, we could preserve the long perforators of the insula, while the short perforators perhaps could be done away with. But this looks very good on an anatomical figure, but on the operating table, it's not often so easy to identify them. So this is how, if you just Google how you go from place A to place B, if this was to go from the surface to the depth of the insula, you would have 4 routes: transsylvian, transtemporal opercular, transparietal opercular, and transfrontal opercular. I'll quickly go through a few videos to illustrate these routes. And this is the spectrum of insular pathology from an epilepsy series. Cortical dysplasia and low-grade astrocytomas, focal ones, continue to be the most common. That is forming about 50% of all insular pathology causing epilepsy. And insular gliomas have always been fascinating, and they always have two perspectives. One is an oncological perspective and one is a seizure outcome perspective. What we need to remember is that, most of them stabilize and they don't have too much of a very, very worrying oncological history. And partial resections too may disrupt the seizure network and have a good seizure outcome benefit. So this is the spectrum of insular resections. We might have just focal resections, or it may be part of large multilobar resections. Insular disconnections are also part of hemispherotomy. So I'll quickly show you a couple of videos. This is the widely split Sylvian fissure, showing you schematically how you could get into the insula. This is the insula, the MCA lying right across parietal operculum, frontal operculum, temporal operculum. So the pathology also influences the surgical approach, the proximity to functional areas. I'll quickly go through a few. These are the pure lesionectomy, extended lesionectomy along with the focal cortical dysplasia, a tailored resection helped by electrocorticography, extended resections. This is the surgical strategy often. Awake craniotomy is an option for dominant insular surgery. I'll quickly show you run through a few pictures. This is a transsylvian insular exposure. So this is a slightly edited video where the Sylvian fissure on the left side is being split, and this is the temporal lobe, this is the frontal lobe, and I'll run through this video quickly in the interest of time. Yeah, so here you can see the MCA, the insula which is coming into view. This is the MCA lying on the surface of the insula, the M2 segment, and here is the insula, and this is a low-grade glioma which is being resected from the insula on the insular cortex. And this is a transtemporal frontal opercular approach where subpial resection helps you to get into the insula. In the interest of time, I'll go a little faster. This is a transtemporal opercular approach. Again, subpial resection and preserving the pia. Sometimes you need to use a combined corridor, all these corridors together to help you to get to the insula. And this is temporal resection along with a subpial resection here of the temporal operculum. So this is a parietal opercular, transparietal opercular approach. You can see a cortical dysplasia of the parietal operculum. This patient, we had used invasive monitoring, and grids were placed, and then we had a transparietal opercular approach. So this is how the postoperative scans looked. This is the insular disconnection in a hemispherotomy. Here we are in the frontal horn of the ventricle, and here you can see the thalamo-basal ganglionic system and the insular cortex being disconnected from the supracortical gray matter. This is the Delalandese approach of a vertical parasagittal hemispherotomy. So yeah, I think I am very close to the end of time. So I'll quickly go through the last few slides. Every insula is different, and morphometry and measurements are very important so that you don't cause complications. Key insular parenchymal and cisternal landmarks are very important for safety, and misadventures, under resections and over resections can be avoided if you keep in mind these morphometric variations, and you could use additional adjuncts like mapping techniques and have these key landmarks in mind. So these are some of the schematic pictures which show the long perforators in the insula, which perhaps need to be preserved when you open up. And this is the nutmeg appearance of the globus pallidus and the putamen, which you see when you go deep beyond the insular cortex. And some of the deficits which are devastating are hemiplegia and dysphasia. But the seizure outcome benefits are still very rewarding in insular epilepsy surgery, about 60 to 75% in Engel class 1, and temporary deficits in maybe about 15 to 20%. We have to avoid the double loser, a person who has a deficit as well as a poor seizure outcome. I'll quickly show you run through a few pictures. A 12-year-old female whom we did a recent resection after stereo EEG. She had MRI negative epilepsy, perhaps a doubtful insular dysplasia. and we did stereo EEG. After an MRI CT angiofusion, we're using a frameless navigation, and this is how we did the technique, using about left-sided 9 electrodes, and this is how it was post-operatively. And we found that the seizures, this is the post-operative picture placement. The mid-insular electrode here was the culprit, and we have just done this about a few days ago. So our fingers are still crossed. You could see very focal ictal onset, a beta buzz from the mid-insular electrode, and we did a very focal. This is the fasciculus, arcuate fasciculus, which is very close to the lesion. I'll quickly show you a video of this resection. This is a transfrontal opercular approach of, we followed the electrode deep into the cortex, and we did a very small, you could see the MCA in the depth through the frontal operculum, and the dysplasia lay just beyond that. So I'll quickly end, this is the focal resection. So a very important message to take home is that the insula is not an island anymore. You know, the safety profile of the insular surgery is very quickly improving, and it's a great mimicker as far as seizure semiology goes. We have to be very, very careful, because there is a concept of pseudotemporal and temporal plus epilepsy, which is responsible for 30% of failed epilepsy surgery. And good results and acceptable morbidity for insular surgery is definitely the future. And so we should respect the insula, but we needn't have any undue fears about it. Thank you so much for this patient hearing. And this is our team here at Sri Chitra Institute, Trivandrum. And I'm very grateful to all of you. As Albert Einstein said, as far as, let us make things as simple as possible, but not simpler than that. Thank you very much.
Thank you very much, George. A very interesting talk. You know, I think it gives us a better picture of epilepsy surgery, especially in the insular region, because like you said, a lot of people are afraid of that region. Anyway, let's get on with the next speaker, as we are a bit short of time. The next speaker, I would like to call Anna Misorocci. Anna is actually a professor in the University of London, and her work is a lot with epilepsy. I believe she's got a lot of papers published over the last 10 years. So let's hear it from Anna.
Yes, can you all hear me?
Yes, we can.
Hi, thank you very much for inviting me, and thank you for the nice talks, which are actually going to make my talk even a lot easier. So today I'm going to talk about the advances in epilepsy surgery, and I'm going to mainly touch 4 topics, which is going to be the use of interventional MRI, the use of 3D multimodality images, the use of robotic assisted surgery, and some non-invasive techniques. George has described it very nicely in his talk. The most important concept in epilepsy surgery is that you have concordance of your data, that everything is pointing to the same part of the brain. So if you have a good hypothesis behind it, then you can go ahead and do a resection. I do mainly adult epilepsy surgery, and there is plenty of literature out there that most often the outcome is better when you are able to completely resect the abnormality. And clearly, when interventional MRI started to be available, has been widely utilized in epilepsy surgery. The main reason being is that you have the advantage of scanning at the time of surgery when the head is still open, and to assess for any small residual lesion that you might have left. This is one of the first papers that came out. Is a group from Germany, and they had a look at 88 consecutive cases of temporal lobe seizures, not for hippocampal sclerosis, lesional cases. And they actually found out that at the time of surgery, about 25% of the patients had a small residual lesion. Now, we all know that when you do temporal lobectomies, you might get towards the end of the case and there is a lot of brain shift. So you might actually do a fantastic job, but you might miss very tiny amounts of lesion that you probably think it's negative and maybe slightly underneath a normal bit of cortex. So having the interventional MRI is a great tool to identify these very small areas of residual. And this is just a case that recently is a patient who had a partial resection in a different institution, and we completed the resection of the temporal lobe. And here you can see the head is open, so we are in the scanner, And, you know, it was a good resection, but I did leave a tiny little bit behind, and that I was able to go ahead and resect at the same time. Another great advantage that we could use interventional MRI for, when it came out, it was the first time we had the chance to integrate all our pre-operative tractography down the look of the microscope. And the first way we used this was to try and improve the outcome in terms of the visual field defect. Now, Abida had a fantastic presentation, and she was able to show you the Mayer's loop and why the Mayer's loop is so important to be protected. In the UK, they're very strict with the driving regulations. So even if you have quite a minor visual field defect in terms of quadrantanopia, you still may not be able to hold a driving license, even if you are seizure-free. And it became apparent to us that the more you use tractography, the more you're actually going to realize that the extent of the Mayer's loop is different from patient to patient. And the idea, it's very simple. If you make your resection anterior to the Mayer's loop, you should protect the patient from having a visual field defect. And this is how it looks down the microscope. So this is a projection of the Mayer's loop, of the optic radiation of the Mayer's loop. And this is just a projection of where the ventricle should be. You will see that actually it pairs up very nicely anatomically. So in a moment, I'm going to open up the ventricle a little bit, and you're going to see how it nicely overlaps, which we put the ventricle only for us to know that our projection was anatomically correct. And the whole idea is that, you know, once you've done the resection, you can see that, you know, our cut in the temporal area is anterior to the projection of the optic radiation. And we were able to do 21 consecutive patients, and none of them failed the driving criteria. So it was an excellent result that we didn't have prior to try and use this technique. Now, 3D multimodality imaging, I think there is a real drive in epilepsy surgery in all sorts of images. And I think it's becoming more and more important today that you can utilize the data of each patient and build your own patient-specific anatomy in a 3D volume. And I think this is fantastic in all the patients, like George was mentioning before, in those patients on which you need intracranial electrode recording in order to make a diagnosis. So those patients in which your pre-surgical data may not all be concordant, or those patients where the data are concordant, but your MRI scan is negative. So you fundamentally need to prove which part of the brain you need to take out. And, you know, there are two ways of doing this. You can cover the surface of the brain with some grids. And this is another approach, which is called stereo EEG, which historically, up until a few years ago, was mainly the French and the Italian school, which is where I originally come from. But now has been widely taking place in the world of epilepsy. First of all, is slightly less invasive for the patient, but also it gives the advantage that you can record from deep foci and find areas that with the grids before we were unable to explore, such as the insula or other parts of the brain. And for sure, the stereo in the stereo EEG approach, what it's difficult is that, you know, with the grids, you open, you see the surface of the brain, you place the grids on top, and you can see what you're going to have to resect. Often, when you're doing stereo EEG, you end up having a resection which is in the deepest part of the brain. And I think the other advantage is that when you can have this type of reconstruction, you can give those to the neurologist, and it's going to help them as well to try and understand how the seizures are spreading, in which anatomical direction, or the various anatomical connections in the brain. And for us, for sure, having all of these pre-operatively, especially the vascular images, everyone who's doing stereo EEG will soon realize that, you know, the neurologists will think that it's very safe, so they want more and more and more electrodes, which is good because they might find more patients to resect. However, this is what we see whenever I am implanting preoperatively, and you know, having 3D reconstruction, it certainly helps finding corridors, avascular corridors where we can safely plan, but also it helps redistributing nicely in the brain areas that you may not have covered enough. And we've been using the 3D reconstruction also to give us targets in MRI negative cases. So this is someone who was implanted where we found out that the electrodes that were responsible for the seizures were in the medial prefrontal cortex. So we built to ourselves for a sort of volume that we wanted to take out. And we were able to put this volume in the interventional MRI. So fundamentally, we transformed an MRI negative case in a lesional case. So we told ourselves that's what we want to achieve and that's what we want to take out. And you can see that this is the scan that we did on the day of surgery when the head was still open. And these were the targets that we wanted to take out, which were where we placed the electrodes that were the one responsible for the seizures. And we were able to know at the time of surgery that everything we wanted to take has been successfully resected. And this is just another example. This patient had way more electrodes than what you see here, but these were just the one responsible for the seizures. And all this data is preoperative. So I've never opened the head of the patient, and I already know where is the vascular anatomy and where are the vessels in relation to the electrodes. You know, if you get to the day of the operation and maybe, I don't know, you lose your navigation for brain shift or because the head slightly moves, you still can carry on your resection because you can compare all your pre-operative images with what you find intraoperatively, and they match beautifully, including, you know, the small entry points of the electrodes on the cortex. And this is just, you can see how the green volume, which we wanted to take out, it really matches beautifully the shape of the resection that we did. Insertion of electrodes are many, many ways of doing it. Historically, it's been frame-based, can be, you know, manual frame-based or frameless. A lot of groups these days are now using robotic assisted. It's a procedure which can be a bit cumbersome, especially if you're putting a lot of electrodes. Gets really difficult to concentrate for long times. It's very repetitive. It's a little bit boring from a surgical point of view. And this is how it's a small robot that we've been using from Medtronic. This was the first prototype, and it becomes a lot easier. It becomes faster and also more accurate. So this all works with a normal navigation system. This from Medtronic. This is just a normal Vertec probe. So you register. We normally use bone fiducials because it makes it more accurate, the registration. And then you put your let me bring it back a bit. You put your robot roughly in the position. Someone press the button and it aligns in a matter of seconds. It beautifully aligns on your trajectory. Now I'm going to go and talk about some known or less invasive options for resective surgery. One is gamma knife and the other one is laser ablation. Gamma knife is stereotactic radiosurgery, and it's so far the only procedure that we can offer the patients, which is under local anesthetic and is a day case procedure. Again, it's fundamental that you have a good hypothesis, that the lesion is focal, it's small, and you can deliver the radiation. There has been a big trial that went on for gamma knife. It was called the ROSE trial. The whole idea was to compare open surgery to radiosurgery, and the hope was to show that it was equipoised in terms of open surgical approach, and that the outcome in terms of neuropsychology was going to be better. It was very clear to us from the very beginning that, one of the advantages of surgery was that, you operate on the patient and it was going to be seizure-free from the day after. And this was only for mesial temporal lobe epilepsy. Why with the gamma knife, that was not such correlation. So the radionecrosis was happening in different time frame for each patient, and also was happening to different extent for each patient. So and look at the scans, how they look like. So that was a mesial temporal lobe case, and this is 10 months after. And this is what happened 1 year after. And this is at 14 months. So if I didn't know that we gave gamma knife, I would have thought that this was a glioblastoma and might have taken the patient to theater. But this is when all the radionecrosis tends to resolve, and you can see you have just a tiny hole in the mesial temporal area. So in terms of results, you can see that they did find out what our impression was at the very beginning, that at 3 months, only 6% of the patient who had the stereotactic radiosurgery was seizure-free, against the 81% in the temporal lobectomy patients. As time went by, the outcome came more similar in terms of seizure freedom. However, in the open temporal lobectomy was still better than the stereotactic radiosurgery. And the perceived advantage that they thought they were going to find in terms of neuropsychology outcome, actually they were not able to prove that, because the hit from a neuropsychology point of view was exactly the same in both categories of patients. And now I'm going to talk a little bit about the laser ablation, which has become in the US the treatment of choice for a lot of patients and a lot of lesions. The operation is very similar to putting any electrodes in the brain. So you have to place a bolt, which is screwed in the skull, and then you just pass the laser catheter, and then there's a sort of thermal ablation that happens. Again, it's done under general anesthetic, and the patient, most of the time, they go home the day after the procedure. So they have treated all sorts of lesions with this. They clearly started from mesial temporal sclerosis. They started from, and then they went to focal cortical dysplasia, heterotopic nodules. I think, the real advantage of this technique is mainly to one pathology, which carries quite high surgical comorbidities when you're trying to operate on, and this is hypothalamic hematomas. We all know that hypothalamic hematomas are deeply located, difficult to reach, and patients might develop a number of hypothalamic issues in the post-op part of the course, which they might require ITU admission. And for sure, this procedure has shown, I think, really an immense advantage to these patients. And here they were able to compare patients who underwent laser ablation for hypothalamic hematomas, where they achieve an 84% seizure freedom, against the 50% seizure freedom, less than 50% seizure freedom, both in the stereotactic radiosurgery and in the open surgical group. And I think I was able to remain in my 15 minutes, and I wanted to show you some of the advances in epilepsy surgery. I think no matter what technology we're using these days, I think we still have to stick to the basic principle, which is having a good hypothesis, knowing what we need to take out, and then all the technology can help in doing this in a safer and in an easier way, but we can't get away from our primary hypothesis of identifying the epileptogenic focus. Thank you very much again for your attention and for inviting me.
Thank you very much, Anna. It was a very interesting talk. And I think a lot of us are captivated that a lot of women are doing great work out there. It's just that maybe we need to showcase ourselves more often. So looks like you did a lot of good surgeries in London. So well done. Yeah. Good. Yeah. So our next speaker will be our very own young neurosurgeon, Nur Huda. She just basically just graduated and finished. And so she's going to present something for us today. Her topic is going to be epilepsy and its surgical management in lower middle income countries. Where are we standing? The scenario, scope, and challenges. So Huda, are you ready? We are tight on time, Huda, so try to keep time. Is she around? Huda? Thought she was around just now. All right, okay. maybe we move on to the next speaker because I don't think Noor is around. We'll try to get her back later. Anila, would you like to introduce Anna?
Sure, Sharon. It's my great pleasure to introduce our next speaker, is Dr. Anamura. Dr. Anamura and I have been friends for quite a long time, and I am so happy and privileged to invite her to this ACNS WIN seminar. Anna graduated in 2009 and then went to France to do a functional neurosurgery. She then completed her neurosurgical training and then specialized in doing functional neurosurgery. She also did a neurosurgery fellowship at UCLA. And currently, Anna is heading as a director for the functional neurosurgery in Brazil. So Anna, podium is up to you. Please start. Anna, you mute.
Hi, thank you so much, Anila, for your presentation. I'm just going to try to.
Okay, do you want to start again?
I think so, huh?
Yeah, start the screen share again. Are you clicking the share screen option? You share at the bottom.
Yes.
Share, yeah. Yeah, click that. That's the first step. Click that. And then pick a screen from the next screen. Are you clicking the share screen option? Click the share screen option.
Yes, I'm looking. Yes.
Okay, when you click that, another screen comes up, right?
Yes.
Okay, click one of those screens to share.
Desktop.
Okay. Yeah, and search and get your PowerPoint. This is a lesson for everybody.
Is your PowerPoint on? Is it on?
Yes.
Keep it as the main page. Don't share your desktop. Click directly on your PowerPoint.
Okay.
Share screen. Okay.
There you go. There you go.
All right, we got it.
Okay, you're on the way. Make the screen larger at the bottom. Okay. There you go. One of those. There you go. Perfect.
Yeah. Thank you. Thank you so much, Anila, for your introduction, for your presentation. Yes, I had the pleasure of meeting Anila for a time, and very happy to be here, to be invited for this meeting. I'm very pleased and happy to participate of this webinar with the title of Hair Disease Presenting with Dystonia Treated by Deep Brain Stimulation. I have no conflict of interest in. What is a hair disease? There is no definition in the literature for hair disease, but we know there is a group of disorders with different etiologies and low prevalence at the most, and the most there are no treatment for it. It ranged from 65 people from 100,000 in the world population. There are approximately 6 to 8,000 different types of diseases, and they can be genetic or acquired. So, dystonia is a sustained movement disorder which is with a cramp that causes pain. So dystonia is a symptom which can become with a lot of hair disease. It ranges from 2 to 50 to 100 million in the world, so very rare. And it is divided by two axes, axis 1 primary, axis 2 secondary, associated with degenerative disorder and dystonia plus. There is a third more common movement disorder after essential tremor and Parkinson's disease. And there is no established treatment for dystonia as there is for Parkinson's disease, for instance. If we're going to talk about movement disorders, of course, we have to talk about tonus and movement. And tonus and movement is very important since we are born. They are validated by Apgar score and when we're born. And talking about tonus, we can have someone with a lot of tonus, which is hypertonia, and not a lot of tonus, less hypotonia. And talking about movement, we have the division of a lot of movement, hyperkinesia, and no movement, akinesia. So we're going to try to reach a point that we can stable all this movement. There is no good treatment if we have no good patient selection. So analysis of the clinical presentation is very important. And if you have a dystonic patient, for instance, the parietal temporal lobe on the cortex is going to send the information that there is a lot of movement for the basal ganglia, and putamen is going to send the information, is going to block the GPI on this network because there are a lot of movement. So we're going to block this group of neurons. The GPI, the globus pallidus internus, is going to excitate the thalamus because GPI is blocked. And thalamus is going to, it's very excitated, is going to block the cortex. And so we're going to have a better network working. So Dr. Seif, Professor Seif, she has a lot of work on this, and she's a world reference on this team. There are no pharmacological treatments available that works for this type of dystonia. If we're talking about generalized dystonia, we have for focal dystonia, which work with botulinum toxin, and we have for dopa responsive dystonia, which is going to work with levodopa. The other treatments, medications, physiotherapy, acupuncture, toxin botulinum, TMS, mindfulness, it not works. So with this evolution, it came some types of surgeries that were gamma knife, for instance, which were very well explained in the previous presentation. We have also the ablation technique, And we have the intrathecal baclofen, which we can implant to help improve. We have the ultrasound, and we have also the deep brain stimulation. A lot of years ago, they believed that all the neurological, psychological disease came from an evil spirit. And the treatment was a hole on the skull to make this spirit go out. Continues with the development. Egges Muniz won the Nobel Prize for doing leucotomy, which is the separation of the frontal and temporal connections. And Walter Freeman, he started to doing a technique which really came with a stigma for the neurological and psychiatric surgery, because he used any metal and pointy object in the ocular orbit and enter, like you can see in the movie, in the patient. So we have a lot of mortality, we have a lot of infection, and so we came with a great big stigma. And Professor Geraldo da Silva, he explains a lot about the impact of this stigma. Getting with the evolution, we have the stereotactic beginning, with Tarlarak, that turned this huge surgery, which was the lobotomy, the frontal lobotomy, to this small surgery, which is the capsulotomy. Less aggressive, less invasive, and more functional. Here comes with the new era treating dystonia, avec Professor Krause, which started with a focused dystonia, and Professor Coop, which I had the privilege of being on his team in Montpellier in France. He started operating the first case on generalized dystonia in the world. So there is this girl that started to develop dystonia. She had all treatment that they could offer. She was intubated, sedated, and still with dystonia. And so she underwent the DBS surgery, and there she is after the surgery. To do DBS surgery, we need to talk about stereotactic, as I showed, or stereotaxy neurosurgery, which comes from the Greek from stereos, solid, taxis, arrange. So we want a point with 3 coordination in the space, X, Y, and Z. And why is that? If I want to be very punctual, if you take a needle, for example, and what is your chance to reach this seed if you just take a needle and get inside the apple? It's not a lot. So if you have these 3 coordinations, it's going to help you a lot to get where you want to. Starting the pre-surgery, we put the arc on the patient head and we fixed, and the patient is going to have the stereotactic MRI. With this, we can get all the cuts from axial, sagittal, coronal. And we can start to plan on the planning station, the target where we want to go. In the surgery, we have to make sure the patient comes with a very aseptic protocol. We are going to use the electrode, so we want to make sure that this is not going to be infected. So it is very important, and I insist on the accepted protocol that you must have in your unit. And the patient goes to general anesthesia for the entire procedure in my technique, in the Montpellier technique. The first part of the surgery, we want to be less invasive as possible. So attention for the incision, attention to trepanation, attention to suture, and the electrode is implanted bilateral to the target. You choose. Usually for dystonia, there are published papers on the thalamus, on the STN, and the globus pallidus internus. Here we're talking about the globus pallidus internus, the GPI. We have a direct anatomical individual visualization to the target. In the planning station, to reach the target, you have available 2 atlas that you can use. But on this technique here, we don't use the atlas. We use the anatomical individual visualization. MRI is more relevant than CT scan to visualize the target implanted. Then patient comes back and have the second part, which is going to be the implanting of the neurostimulations or pacemaker. Sorry, this is the precision is the key. So we must have this precision, and we do for this precision in the OR, we use fluoroscopy, so we can see if we are on the target. And this technique was written by Professor Fribo, Professor Koops, Dr. Elferty, Professor Sif, and the team. After we want an MRI to see if we reach the target. So we control if we are really on the target we have chosen. Postoperatively, we have the neurostimulators, not just under clavicle, but we have also in the belly or inframammar. We have 3 companies for the neurostimulators and the electrode in the world so far. So it can come with some complications that we must be sure that we explain to the family and the patient, and we make sure, of course, that we are not going to have. So infection, extrusion of the skin, electrode breakage, or hemorrhage, it's written in the literature. Not a lot. You can see here like 2 cases in 86 patients, so it's not a lot. For epilepsy, for instance, there can come migration of the electrode 4 in a population of 79, so it's not a lot. Here is a dystonia plus, one of my patients I want to share with you. He had deep brain stimulation for this dystonia, tremor, akinesia, and day 3 post-operatively, we migrate from these symptoms for this one. Conclusion, several brain circuits are accessible and their activity can be modulated in dystonia and dyskinetic syndrome, as I just mentioned. We don't know if symptomatic and disease modifying with this technique. Multidisciplinary team is needed, engineers, radiological, neurosurgery, neurology, psychiatry, psychologist. And with this, we can have the expansion of indications. And the most important is the hope to help more and more patients. Thank you.
Thank you so much, Anna. I think we're a bit short of time. So let's go on with Noor. Noor, are you ready?
Yes, ma'am, I'm there. Hello.
Yeah, can you start presenting?
Thank you. Madam, can you see my slides?
Yes, we can.
Yes.
Thank you so much. First of all, I would like to thank you for accepting me and for allowing me to present my humble work at this very prestigious webinar. The topic of my presentation is epilepsy and its surgical management in the low middle income countries. Where are we standing? And what is the scenario? What will be the scope and the challenges that we will have to face in case of extending this? As we all know that about 2-3% of the world population is being affected with epilepsy, but there is unfortunately some predisposition that is unequal distribution of epilepsy in the low middle income countries. So you can see that about 80% of epileptic patients belong to the low middle income countries. There are various causes that are already that can be explained and they are potentially preventable. That includes birth injuries, perinatal injuries, CNS infections, and a relatively more incidence of trauma, especially childhood trauma in the low middle income country that has shifted this balance towards our part of the world. But the thing is, only 25 to 37% patients are able to get treated properly. And ironically, 73% patients do not receive any sort of treatment at all, while surgery is quite sparse in our part of the world. Even if a patient is being adequately treated, even in that case, about a third of those patients will suffer from refractory epilepsy and intractable epilepsy that make them a very eligible candidate for surgical management. But surgical management is still an underrated, rather an undeveloped domain of neurological surgery in our part of the world where it is needed the most. The burden of disease can be very easily understood that while epilepsy is the 36th leading cause of DLI worldwide, but in a few LMICs it is about 21st and 14th cause of DLI respectively. So what we wanted to know in our study was to evaluate the current scenario of epilepsy surgery that is being, held in these low middle income countries. So we actually involved our colleagues from other part of these LMICs that include India, Bangladesh, Afghanistan, Libya, Syria, Iraq, and Egypt, along with Pakistan, and we performed a survey and also did literature review from PubMed, Scopus, Curious, and ResearchGate on the availability of epilepsy surgery, specialty training, national guidelines, epilepsy surgery dedicated centers, levels 1, 2, 3, and 4, as well as those challenges of surgery that are being found in the literature. What we asked about epilepsy surgery among our colleagues from other low middle income countries was the availability of epilepsy surgery facility in their countries, and do they regularly perform the surgery, and what are are the status of the trainees? Have they been even exposed to that surgery or being taught that this domain, very important surgical procedure? Is there any training program, any national training program for epilepsy surgery in their countries? Is there any, at least one dedicated center, no matter what the level is, any center that is present in their country? And what is their assessment of the patient interest and also the level of interest of the neurosurgeon to join epilepsy surgery later as a first specialty? So according to a survey, while the literature is quite sparse in that in this subject, but according to one survey conducted by the World Health Organization with the International League Against Epilepsy and the International Bureau of Epilepsy in 2006, epilepsy surgery is available in only 13% of the low middle income countries as compared to the 66% high income countries. So it is, there's a huge gap, we can say. What we want to share here in our study is, first of all, let me start from Pakistan. The first center, epilepsy center, was established in Jinnah Hospital, Karachi, Jinnah GPMC, as we know it, in 1989, but it did not have any surgical facility. Later on, Al Khan Hospital established a surgical epilepsy center, and that was in collaboration with the high-income countries, and they did a lot of telemedicine and provided the services. Still, in public sector hospitals, there is scarcity. Most of us have not been exposed to any sort of, like we have not, most of the residents have not even observed a single epilepsy surgery. A few private sector hospitals perform it sparsely, but we do not have that sort of percentage that was very commonly available. There is no special guideline in Pakistan regarding epilepsy management, and there is no specialty training or fellowship that is available in our country. So if someone has to get training, he or she has to go abroad in that and find some fellowship like that. But most of the time, people are spending quite a lot of time in their exit exam, and they they pass that very important time preparing in this exam and etc. That they surpass that period of time when they are going to do fellowships and things like this. So this is something that is very unfortunate situation. Level 3 epilepsy centers, there are those centers there where you can find some surgical management. There are level 3 and 4. I would like to explain here. So level 3 epilepsy centers are available in Indonesia, Philippines, Thailand, and Vietnam. And Indonesia and Thailand have at least one level 4 epilepsy center. More than 39 centers in India are regularly performing epilepsy surgery, and they are very much well equipped. So it is quite developed here. In Bangladesh, rapid development in this surgery have been taking place. In Iran, most of the specialized tertiary care hospitals do have epilepsy facility, and that is very impressive. Many young neurosurgeons of our generations, especially those who are working at public sector, have not been exposed to any such operation during their residency time. In our survey with our colleagues, we came to know that only 10% neurosurgeons have observed even a single surgery during their residency tenure in their own countries. The common epilepsy surgery that people have observed in the LMIC were anterior lobectomy. 25% of our colleagues from low middle income countries confess that they have at least one epilepsy center in their country. 60% said that they find a patient interested in epilepsy surgery, and if it is available, they would go for it. That is, if we want to say that, will there be any benefit if we establish epilepsy surgery in our country? Then yes, we would have, because in 60% of our patients are actually interested, if we counsel them properly, that they would like to go for surgery for their refractory illness because they think it is very cumbersome, that they will lead to complication in their life. So this is something that is very important. 30% had at least one dedicated center. 60% neurosurgeons showed interest joining epilepsy surgery as a future specialty if it is available in their country or if they find time. Only 20% had a national training program for epilepsy surgery. In questions related with the challenges for epilepsy surgery, everyone agreed that it is because of lack of trained personnel who can train the other generation of neurosurgeons, the next generation of neurosurgeons. So this is something that is very important. 70% of our colleagues neurosurgeons from LMIC said that their hospitals are not well equipped to perform epilepsy surgery, and the doctors are not quite interested in getting their training for epilepsy surgery. They're those who are, who are already established. They think that obviously they are more than interested. They are much busy performing their regular surgeries that they do not have any time to go and do fellowships. Again, like I will say that it is such an instrument. People are more enthusiastic in finding a specialty to follow, where they could go and just find something interesting. So most of the seniors are already much well established in their specialties that they would never go and change. Obviously, for obvious reasons, they will never change their specialty. 60% mentioned that the cost of surgery is a challenge in their country. That is very true. So what we conclude is epilepsy is a huge yet and ignored issue of the low middle income countries. There is lack of management facilities for epilepsy in the low middle income countries. While patients do intend to look for surgical options for refractory epilepsy, the few important factors that may be playing a role in the lack of this surgical facility is because this domain of surgery has not been paid attention at all. So what we need to do is to raise awareness for epilepsy and the proper management of epilepsy and the surgical management to make it possible to provide this very important management for those who are in need. So there is need to raise awareness. This is a very important time. There's a lack of trained personnel to perform this facility, a lack of well-equipped unit, as well as a lack of specialty training in the field. So, many people do not have the resource to go abroad and find any fellowship. So unless we provide national training programs, we cannot, expect to have a lot of trained personnel locally. So this is something that we should pay attention to. There's something that was some relevant point that I wanted to share is there are preventive steps for epilepsy in low middle income countries that we can actually have some type of cautious that we could practice in order to prevent these cases by proper perinatal care and avoiding perinatal injuries. Law enforcement to prevent head injuries and treating CNS infections in time. This is very important, especially CNS TB is quite common in our part of the world and other infections that have been left untreated, especially from the periphery of our countries. There is a study from Tanzania that suggested the association of adverse perinatal event with epilepsy with an odds ratio of 14.9 with a 95% confidence interval. So that suggests that epilepsy can be prevented with better antenatal and perinatal care. So this should be paid attention to. Again, thank you so much for allowing me to present my work, and I'm really happy to share this picture of WINS 2018 at Kuala Lumpur, Malaysia. One woman can make a difference, but together we can rock the world. So thank you again for your patience lately.
Thank you very much, Noor. A very informative presentation. Yeah, I think it sums up what most of us in the low middle income or maybe the third world countries are facing when it comes to functional and epilepsy surgery. So our final speaker is actually our very own secretary, ACNS WINS, Anila Daba. She's actually currently the medical director and head of neurosciences and senior consultant of neurosurgery at Mukhtar Al-Sheikh Hospital in Multan. She's a former assistant professor of neurosurgery at Aga Khan University. And she actually pioneered the Women in Neurosurgery chapter within the Pakistan Society of Neurosurgeons. So today, Anila will be talking to us on vagal nerve stimulation for intractable epilepsy. Okay, Anila, take away, take the floor. You're mute, Anila. You're mute. You're mute.
Sorry about that. Sharon, thank you for the lovely introduction. And I'm just happy with my fellow colleagues of the ACNS WINS chapter for organizing this. Thank you, Sharon. Thank you, Abida and Sneha. And we really work wonderfully together to bring these webinars. And this is the first of the series for the year 2021. We have done these before in the pre-COVID times, of course. I'm going to start sharing my screen here. Can everybody see the screen?
Yes,
we
can see.
Okay, great. So this is the last bit of the epilepsy surgery, which is about the vagal nerve stimulator for intractable epilepsy. And some call it the pacemaker for the brain. I call it the VP shunt of the brain. A VP shunt of the epilepsy, sorry, a VP shunt for the epilepsy surgeries. And, as what Noor said, that the big problem with the LMIC countries is actually the cost of care. And the vagal nerve stimulators, just like the deep brain stimulators, are extremely expensive devices to be bought by a population that is 90% at poverty levels. We don't have huge epilepsy centers where we can do a lot of EEG recordings and video recordings or do the subdural electrode placements. There are only 1 or 2 centers in Pakistan who actually does very extensive epilepsy work. And one of them is the Aga Khan University, Karachi, where I also work. And there we can actually find patients who can actually afford a vagal nerve stimulator. And that was the reason that we were actually able to do our first vagal nerve stimulator in Pakistan recently. And I'm going to be just presenting a short talk about what a vagal nerve stimulator is about. So over 3 decades ago, it was found that intermittent electrical stimulation from the vagus nerve induces inhibition of neural processes, which can alter brain activity and terminate seizures. And through this, the vagal nerve concept was introduced. What is a vagal nerve? It is an FDA-approved device which is designed to prevent seizures. There are also other indications for vagal nerve stimulator, which will be on my next slide. And the idea is to send mild impulses of electrical energy to the brain via the vagal nerve. And as I said, some people call it the pacemaker for the brain. The more common indication for the vagal nerve stimulator is actually intractable epilepsy. And it's been out there for 3 decades and it's been used, and it's very commonly used for people who have intractable epilepsy. And there are tons of research papers out there which actually show that the intensity and frequency of the seizures are reduced by 50% in the management of refractory seizures. VNS has also been shown to promote neurogenesis in the dentate gyri of rat hippocampus after 48 hours of stimulation of the vagus nerve. Improvement have also been seen in non-psychotic major depression from a randomized controlled trial that was done about 7 years ago. VNS is also effective in obesity management, especially in people who have depression. So the 2 more common indications that have emerged for the last 3 decades is number 1, the intractable epilepsy, and number 2, patients with depression. A little bit about the history of vagal nerve stimulation. In 1934, Sommerweiss proposed that the compression of carotid sinus produced a direct cerebral response, which causes syncope in human beings, which was different with the effect of stimulation on blood pressure or heart rate. And in 1938, Bailey and Bremer reported that vagal stimulation caused electroencephalographic changes. Den and Olson in 1951 showed that the stimulation of the cut cervical vagus nerve evoked responses in the VP and interlaminar regions of the thalamus. And in 1985, Zabara reported that electrical stimulation from the vagus nerve produces inhibition of the neural patterns in the brain. So as I said, that the 2 more common indications have come up to be the intractable epilepsy, and number 2 is depression. And the biggest thing is that the goal is actually not a cure from the epilepsy. The goal is only to reduce the amount and severity of the seizures. These are patients who you are unable to find a focal area from which the epilepsy is originated, as you saw from the talks of Anna, that the concordance of an epileptic focus is very important by different methodologies to find out where is the seizure focus, so that that can be surgically removed. But if there is no seizure focus, or the patient are on multiple seizures, medication, anti-seizure medication, like 4 or 5 medication, and in spite of that, you have seizures, or patient who do not want to undergo a surgical resection. Maybe in LMIC, the biggest reason is the amount of money that you have to do. You have to spend in a hospital to find that focus of the seizure. Could be one. Now, this device is usually surgically implanted in the left chest and axilla, and the coils are usually wound around the left vagal nerve, and the stimulation is automatic. And the patient can also additionally stimulate the device if the aura occurs. So the question is, why left and why not the right vagal nerve? So vagal nerve stimulator implantation is usually done on the left side so as to avoid the cardiac complications. The right vagal nerve supplies the sinoatrial node, where the left innervates the atrioventricular node. So this prevents the untoward effect of cardiac dysrhythmia. Otherwise, the patient would be getting cardiac rhythm abnormalities every 3 minutes. So there are 3 mechanisms of action that have been proposed that how the vagal nerve stimulator works. One of them is a synchronization theory. So we know that the complex partial seizure usually arises from the limbic cortex, which is very well explained by Abida, which is the amygdalo-hippocampal entorhinal cortex synchronization, which causes a complex partial seizure. So when a VNS implant is implanted, it's somehow that electrical impulse called the desynchronization of that whole circuitry, and as a result of which the severity of the epilepsy is decreased. Second is a neurotransmitter theory, and this says that this has to do with the neurotransmitter norepinephrine, with the locus coeruleus, and as a result of which inhibition to that areas can actually cause decrease in the seizures. The third theory is the cerebral blood flow theory, because when you have seizures, there are massive alteration to the blood flow in the entire brain hemisphere. And it is proposed that maybe that increased amount of blood flow also activates the inhibitory areas and thus decreases the seizure intensity. So there are usually 3 parts of a vagal nerve stimulator. One is a program generator. They are lead with 2 to 3 coil, and then there is a handheld magnetic device. This is how a vagal nerve stimulator looks like. The initial part is actually to perform a surgery over here to expose the carotid sheath. Usually the vagus nerve is situated between the jugular and the internal carotid artery, and it's really a thin nerve, and it's quite superficial. You are able to access it very easily. The biggest task is, of course, to wind these plastic wires around this thin nerve, and then there is some coiling just for the stretch, and then it is placed in the generator, which is placed in the pocket just a little below the clavicle. So what happens is, usually when you place the vagal nerve stimulator, at that time, there is only programming done enough to make sure that the leads are working and the battery is operational, but the setting is not adjusted, because to set what kind of electrical impulses that patient is going to get is usually determined by the epileptologist. And it is usually done about 3 weeks after in an outpatient setting. And again, it is tailored. It is usually starts with very low electrical impulses. As the patient starts getting used to it, then the electrical intensity is increased. This is a little surgical demo of a vagal nerve stimulator placement, and as you see, you can give a vertical incision or a horizontal incision. Horizontal incision usually cause a good cosmetic scar. So within the neck creases, you open, it's just doing a simple regular anterior cervical discectomy and fusion kind of a procedure. You split the platysma, you find the sternocleidomastoid muscles, you go medial to the sternocleidomastoid muscle, deep into the avascular plane to find the carotid sheath. Once you find the carotid sheath, you find the jugular and the carotid artery. And usually the vagal nerve is situated in between, and then the electrode placement is usually done on the vagal nerve stimulator. There are certain techniques of placing these electrodes, and usually when you are placing it, the central electrode is actually placed first. And because one of them is actually ground and the central one is actually the real electrode. So that's the one that's placed first, is wound around, then the top and the bottom part of the wire, the coil is placed. Next, what you do is you just anchor it a little bit around the surrounding muscles so that it doesn't stretch out, because these coils are very tiny and delicate, and a little stretch can actually pull them out from the vagus nerve. And then you just bring them out, and then you again suture it. There are several of these that are provided within the vagal nerve stimulator kit, and some of them are placed inside and some of them are placed outside. And again, you make a little coil of the loop underneath the skin. And again, this is so that it doesn't stretch out when you're stretching your neck. And then you just close it like you would close an ACDF incision. And that's again the same cartoonic image of the procedure that I had just described above. Here you can see the jugular vein, the carotid artery, and the vagus nerve, which is in between. Usually quite about almost a 4 centimeter vagal nerve has to be separated out and isolated and skeletonized. And this loop is usually placed so that you can wind the electrode completely around the vagal nerve, which is very important. The electrodes are usually placed in the left vagus nerve, as I told you before, and this is how it looks in real life. And then the battery is then placed here. A couple of different things that I've seen in vagal nerve surgeries, because although I have performed it first time in Pakistan, but I have been performing vagal nerve surgeries in the US before. And one of the things that I've seen is sometimes you can actually have 2 vagal nerves coming out of the same division. So there's one, and then there's a branch of other vagal nerve that comes out from the main trunk, which is the same size as the big trunk. So the choice always is that which one to place the electrode on, and I had always chose to place it on the main trunk. This is something that I've seen a couple of times in my life before. And again, this is a technical picture of how to place these electrodes. There's a center bit has to be placed, and then the plastic just recoils around the vagus nerve. And again, another cartoonic image of the same. So this one is a negative electrode, one is a positive electrode, and the third one is the anchor. So basically, this is the one that needs to be placed first, and it's the most important one. And then the anchor, as I said, so that the neck doesn't stretch out. And this is the VNS generator and the lead complete set. And these are how the scars look like. What happens after 3 weeks after the, okay, so a couple of things that happens immediately after the vagal nerve stimulator placement. One is that because of the inflammation around the vagus nerve, there's an immediate decrease in the seizure activity in the first week after the placement. So usually the patient comes and says they're very happy, although the stimulator is not turned on, but they still feel that their seizures have become better. And that happens because of the initial inflammation of the vagal nerve. And as the week subsides and the inflammation goes down, the seizure activity again increases as the baseline. By the time the scars are healed, within 3 weeks, they come to the clinic. And at that time, the initial, the very, very basic setting is placed by an epileptologist. And these are some of the side effects that usually happen. So whenever the vagus nerve is stimulated, there will be a tiny hoarseness. So after every few minutes, you will see that the patient will have a little hoarse voice, you know. Sometimes they can also have cough or a throat discomfort. If they have dyspnea, then definitely you have to change the setting of the stimulator that you have placed. The complications that can happen from vagal nerve stimulator is a dislocated electrode that can happen, a lead fracture, the device can be malfunctioned, especially the batteries. Sometimes the handheld device that changes the electrical stimulation have battery issues, and that's the reason you get an error. Wound infection is quite common, and if the wound infection happens, if it's just in the battery pocket, then you can just remove the battery pocket and change the battery after the infection has subsided. But if it is tracking along the entire wire, then you have to remove the whole device. Transient vocal cord paralysis can occur, but usually it's not permanent. Cardiac dysrhythmias can happen, and death can happen if the stimulation is too high. And usually the treatment for a dislocated electrode is exchange the electrode. If a lead fracture happens, again, you exchange the electrode. Device malfunction, you exchange the generator. If there is a wound infection, you can revise it with X implantation and the reimplantation, depending whether it's a battery or the entire lead. If you have a transient vocal cord paralysis, you can start the speech therapy. And for cardiac arrhythmias, you usually give atropine. So in conclusion, I just want to say that vagal nerve stimulator is a technique, placement of a vagal nerve stimulator is a technique which is present for 3 decades and is a very important armamentarium of epilepsy treatment beside the epilepsy surgery, commonly used in the entire world. A little difficult for the MIC countries because of the very expensive device, and only very, very few centers can actually do it. And it helps in reducing the seizures to about, decrease in the seizure intensity is about 50%. With that, my talk is finished, and I just want to say thank you.
So thank you very much, Anila, for such a interesting and concise talk on vagal nerve stimulators. I think everybody, gained a lot from that talk.
Thank you.
Very straightforward, very direct. I think it's simple and easy to understand. I think we've come to the end of the webinar because of the time limitation of the webinar. It's the past 2 hours. I think the committee had a great time organizing it and getting a good group of panelists as speakers for this functional and epilepsy surgery. We hope to have more, and we will have more in the coming months, and we will keep you all updated. We have a quiz that we have actually prepared, but due to the time limit, we can't do it now. We will email the quiz to all of you, and we hope that you will actually participate and send back, email it back to us, and we will send out the certs to you all. All right, so if you participate in the quiz, you will definitely get a cert. So thank you all for coming and sharing your time with us tonight.
Sharon, please, would you announce about our webinar next Friday?
Yes, so next Friday, there is a webinar with the Egyptian Wind Society chapter. It is on the 26th of March. I know it is 8 o'clock Malaysian time. So it is 6:30 Egyptian time, is it?
Yes, it is from 2 to 4 p.m. Egypt time. You are one of the honorable speakers, and of course, Professor Yuko Kato and Abida and all of you.
Yeah.
Thank you, Sharon. Thank you very much.
Okay, I'd like to thank all of you for coming. I've got to run. We have Yuha in China televising now. So I'd like to thank, I'm sorry we have to go. So thank you, and we'll see you at the next webinar.
Okay, thank you.